Superior labrum anterior to posterior tears and lesions of the proximal biceps tendon. Kamal Gokuz, Associate Professor. Tashkent University Alanya Research and Practice Center. This video was produced from the book source that was shown below. Boy Martin I. 2014. ALS Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Acknowledgement. We would like to acknowledge the editor Boyer Martin I and chapter author Mark S. Kowalski, MD, in preparing the text of this chapter in the previous edition. Citation. Boyer Martin I. 2014. ALS Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Introduction. A superior labrum anterior to posterior, SLAP, lesion is the detachment of the superior portion of the glenoid labrum, including the anterior and posterior aspects. The long head of the biceps brachii tendon at its insertion may or may not be involved. Typically occurs in patients who perform repetitive overhead activities, such as the overhead athlete, but also may occur in acute trauma. Anatomy. The glenoid labrum consists of parallel collagen fibers that course around the circumference of the glenoid. The superior labrum inserts on the superior glenoid rim, medial to the articular cartilage margin, through a transitional zone of fibrocartilage. A normal synovial recess exists between the meniscoid or triangular superior labrum and the articular cartilage extension over the superior glenoid rim. Vascularity to the glenoid labrum originates from the scapula, circumflex scapula, and posterior circumflex humeral arteries via capsular or periosteal vessels, figure. Of the biceps tendon, 40% to 60% attaches to the supraglenoid tubercle 5 mm medial to the superior glenoid rim, the remainder attaches directly to the superior glenoid labrum. Anatomy. The biceps tendon typically attaches entirely, type 1, or predominantly posterior, type 2, on the superior labrum. Alternatively, the labral attachment of the biceps tendon may have equal anterior and posterior contributions, type 3, or, less commonly, predominantly anterior, type 4. The biceps tendon is an intra-articular but extra-synovial structure within the glenohumeral joint. Vascularity of the biceps tendon is provided primarily by the ascending branch of the anterior humeral circumflex artery, which travels within the bicipital groove. An avascular zone exists at its proximal portion, close to the superior glenoid. The biceps tendon passes through the bicipital groove, or intertubercular groove, between the greater and lesser tuberosities. Stability of the biceps within this region is afforded by the biceps sling, or pulley, consisting of fibers from the A. subscapularis tendon, B. supraspinatus tendon, C. coracohumeral ligament, D. superior glenohumeral ligament. Anatomy. The biceps tendon typically attaches entirely, type 1, or predominantly posterior, type 2, on the superior labrum. Alternatively, the labral attachment of the biceps tendon may have equal anterior and posterior contributions, type 3, or, less commonly, predominantly anterior, type 4. The biceps tendon is an intra-articular but extra-synovial structure within the glenohumeral joint. Vascularity of the biceps tendon is provided primarily by the ascending branch of the anterior humeral circumflex artery, which travels within the bicipital groove. An avascular zone exists at its proximal portion, close to the superior glenoid. The biceps tendon passes through the bicipital groove, or intertubercular groove, between the greater and lesser tuberosities. Stability of the biceps within this region is afforded by the biceps sling, or pulley, consisting of fibers from the A. subscapularis tendon, B. supraspinatus tendon, C. coracohumeral ligament, D. superior glenohumeral ligament. Table, adapted with permission from Maffitt M.W., Gartzman G.M., Mosley B., Superior labrum biceps tendon complex lesions of the shoulder. American Journal Sports Medicine 1995. 23-1. Pages 93 to 98. powerless E, Nord KD, RIURKN, the diagnosis, classification, and treatment of SLAP lesions. Operative Techniques Sports Medicine 2004 12:99 to 110, Snyder S.J., Cars L.R.P., Del Pizzo W., Fekel R.D., Friedman M.J., SLAP lesions of the shoulder. Arthroscopy 1990. 6-4. Pages 274 to 279. Pathophysiology. The glenoid labrum enhances glenohumeral joint stability by increasing the surface area of the glenoid and by serving as an attachment site for the glenohumeral ligaments. The superior labrum/biceps anchor complex serves as a secondary restraint to anterior translation in abduction and external rotation. The long head of the biceps brachii has been described as a static humeral head depressor and a secondary stabilizer to anterior and posterior translation, but it has not been shown to serve an important dynamic role in glenohumeral joint kinematics or stability. Various mechanisms have been described in the pathogenesis of superior labral tears, including 1. Direct traction to the biceps tendon. 2. Internal impingement. 3. Peel back. Unique aspects of glenohumeral joint kinematics in the throwing athlete are relevant to the etiology of superior labral tears. Contracture of the posterior band of the inferior glenohumeral ligament exerts a posterior force on the ligament, which tethers the humeral head and shifts the glenohumeral contact point postero-superiorly in composite abduction and external rotation. This posterior-superior shift allows hyperexternal rotation at the glenohumeral joint by avoiding abutment of the greater tuberosity against the posterior-superior glenoid and by increasing the redundancy of the antero-inferior capsule. This posterior-superior shift in the humeral head with resultant hyperexternal rotation explains the exacerbation of internal impingement of the rotator cuff on the posterior-superior labrum and the peel-back mechanism of superior labral tears. This posterior-superior shift allows hyperexternal rotation at the glenohumeral joint by avoiding abutment of the greater tuberosity against the posterior-superior glenoid and by increasing the redundancy of the antero-inferior capsule. This posterior-superior shift in the humeral head with resultant hyperexternal rotation explains the exacerbation of internal impingement of the rotator cuff on the posterior-superior labrum and the peel-back mechanism of superior labral tears. This posterior-superior shift allows hyperexternal rotation at the glenohumeral joint by avoiding abutment of the greater tuberosity against the posterior-superior glenoid and by increasing the redundancy of the antero-inferior capsule. This posterior-superior shift in the humeral head with resultant hyperexternal rotation explains the exacerbation of internal impingement of the rotator cuff on the posterior-superior labrum and the peel-back mechanism of superior labral tears. Diagnosis. A history of acute trauma, consisting of sudden traction or compression to the affected extremity, may be present. B. SLAP tears can be associated with a previous subluxation or dislocation event. C. Insidious onset of symptoms associated with SLAP tears is most common in overhead throwing athletes. D. Pain caused by a SLAP tear often is localized deep within the glenohumeral joint and can be associated with mechanical symptoms, fatigue or a dead arm sensation of the extremity during overhead activities, or frank weakness of the rotator cuff in a concomitant paralabral cyst. Diagnosis. Various provocative tests have been described for SLAP tears and biceps pathology, but none have sufficient accuracy to confirm the diagnosis. 1. O'Brien active compression test. The affected extremity is positioned at 90 degrees of forward elevation, slight adduction, and maximum internal rotation. The patient performs resisted forward elevation. The test is repeated in maximum external rotation. The test is positive if pain occurs deep within the shoulder in maximum internal rotation, then improves with maximum external rotation. 2. Crank test. The affected extremity is elevated to 160 degrees in the scapular plane. Axial force is applied to the extremity while the humerus is passively rotated. The test is positive if pain, clicking, or catching is reproduced. Biceps load 1 and 2 test. the affected extremity is abducted to 90 degrees to 120 degrees and maximally externally rotated, the forearm is maximally supinated, and the elbow is flexed against resistance. The tests are positive if pain or apprehension worsens with resisted elbow flexion. Anterior slide test: the hand of the affected extremity is placed on the hip with the thumb posterior. One hand of the examiner is placed on the elbow of the affected extremity, exerting a slight anterior and axial force to the extremity. The patient is asked to resist this force to the elbow. The test is positive if pain, a pop, or a click is reproduced. Speed test: the affected extremity is elevated to 90 degrees in full supination with the elbow extended. The patient resists downward pressure on the extremity by the examiner. The test is positive if the pain is experienced in the anterior shoulder or glenohumeral joint. Yergesen test: the affected extremity is adducted against the side with the elbow flexed to 90 degrees in full pronation. The patient then supinates against resistance. The test is positive if the pain is experienced in the bicipital groove or glenohumeral joint. Speed and Yergesen tests demonstrate poor sensitivity, moderate specificity, and poor accuracy. Diagnostic: injection of local anesthetic with or without corticosteroid into the glenohumeral joint or bicipital groove may aid in confirming the diagnosis. Including two sensitive tests, active compression and crank tests, and a specific test, speed test, increases the overall accuracy. Physical examination should include an assessment of rotator cuff strength and infraspinatus atrophy to identify patients who may have suprascapular nerve compression from a paralabral ganglion cyst. An instability examination should be performed. Assessment of throwing athletes includes the total arc of rotation to identify those with a glenohumeral internal rotation deficit. MRI is the imaging modality of choice. 1. Diagnostic accuracy of MRI may be improved with the addition of intra-articular contrast or by positioning the arm in abduction and external rotation. 2. Diagnostic accuracy of MRI ranges widely in the literature. Accurate diagnosis is predicated on an indicative clinical examination and MRI findings and cannot be confirmed until the time of surgery. Ultrasonography can be useful in the dynamic assessment of the biceps tendon. 1. Treatment based on classification. A. Type 1 degenerative tears typically demonstrate fraying, with an intact biceps anchor. Debridement alone is sufficient. B. Type 2 tears are unstable due to the involvement of the biceps anchor. Reattachment of the labrum to the superior glenoid rim is indicated. In patients older than 40, biceps tenodesis may be preferred over slap repair secondary to concerns for complications such as re-tear and excessive stiffness. C. Type 3 tears are managed by debriding the unstable bucket handle labral tear. D. Type 4 tears are managed given the status of the torn biceps tendon. If less than 25% to 50% of the biceps tendon is involved, the tear and its extension into the tendon are debrided. If 25% to 50% or more of the biceps tendon is involved, biceps tenodesis or tenotomy with labral debridement or repair is indicated. Treatment. 2. Technique. A. Portals. Viewing. The standard posterior viewing portal typically is used. Working, anterosuperior and antero-inferior portals. Alternatively, the portal of Nevisser can be used to pass the shuttling device beneath the labral tissue, 1 cm medial to the acromion at its junction with the scapular spine and posterior border of the distal clavicle. Anchor placement, anterosuperior rotator interval portal. An accessory transrotator cuff posterolateral portal can be used for anchors placed posterior to the biceps tendon. The portal of Wilmington also has been described for this purpose, pierce cuff at myotendinous junction. The transrotator cuff portal has been used in a cannulated manner for anchor placement and suture shuttling. B. Fixation. Various techniques exist for anchor placement and suture configuration during superior labral repair. Overconstraining of the biceps anchor should be avoided. Treatment. Ideal anchor placement depends on the anatomy of the patient's biceps insertion on the superior labrum and the anatomy of the labral tear. Knotless implants eliminate the need for arthroscopic knot tying and, with a horizontal mattress suture configuration, decrease the potential adverse effects of bulky intra-articular suture material. C. Concomitant pathology. Paralabral ganglion cysts, often accompany SLAP tears and should be recognized on preoperative MRI, can cause suprascapular nerve compression and resultant rotator cuff weakness, can be decompressed using aspiration at the time of surgery. Subacromial bursitis. Subacromial procedures performed in conjunction with a superior labral repair should be done with caution because they may increase the risk of postoperative stiffness. Rotator cuff tear. In a patient with concomitant rotator cuff and superior labral tears, it is imperative to determine whether the SLAP tear is an incidental finding or if both lesions contribute to the patient's symptoms. If so, repair of both tears may be indicated. In patients older than 50 years, superior results have been achieved with rotator cuff repair and biceps tenotomy. D. Biceps tendon pathology. Indications for surgery include asymptomatic slapped ear with biceps involvement, tearing of the tendon of 25% to 50% or more of the tendon subluxation or dislocation due to disruption of the biceps pulley, or intraoperative findings consistent with tenosynovitis or tendinosis, with concordant preoperative examination and imaging. Alternative treatment primarily includes tenotomy or tenodesis. In biceps tendon instability, acceptable outcomes have not been achieved with pulley repair or reconstruction. Biceps tenotomy benefits include the technical ease of the procedure and of the post-operative rehabilitation, and advantages in elderly, less active patients, who, along with patients with large arms, are less likely to be negatively affected by cosmetic deformity, cramping, or fatigue of the biceps muscle. Biceps tenodesis, removal of the intra-articular portion of the tendon, a pain generator, with more distal reinsertion of the tendon to maintain the length-tension relationship of the biceps muscle. Concern exists that proximal tenodesis may be associated with a higher incidence of persistent pain due to the preservation of a potentially pathologic tendon and tenosynovium within the bicipital groove. Distal tenodesis, below the groove in a suprapectoral or subpectoral region, removes the biceps tendon from the joint and bicipital groove, thus mitigating the risk of persistent postoperative pain. Soft tissue fixation. The biceps tendon can be reinserted with a variety of implants. The simplest technique relies on the interference of the bulky tendon against the entrance of the biceps pulley or on fixation to the overlying rotator interval using a suture. Osseous fixation. Arthroscopic or open tenodesis can be performed with more rigid fixation of the tendon to bone, including suture anchors, cortical buttons, or interference screws, which demonstrate the highest fixation strength. Tenotomy has been associated with cosmetic deformity, cramping, fatigue, and reduced supination strength. No evidence of the overall superiority of tenodesis exists in the literature. 3. Rehabilitation. A. Postoperatively, the surgical extremity typically is protected in a sling for about 4 weeks. B. A gradual, progressive range of motion protocol is begun immediately. A full range of motion should be achieved within the first 6 weeks. C. Strengthening, beginning with the periscapular musculature and advancing to the rotator cuff, typically begins at approximately 4 weeks. Dynamic functional activities are introduced at 3 months, with a return to sports deferred for at least 6 months. D. Rehabilitation should be modified to account for the concomitant treatment of associated pathology. 4. Outcomes. A. Modern techniques and implants have been associated with favorable results after SLAP repair in both pain and return to function. The ability to return to sports is unpredictable, however. B. In managing SLAP tears, some evidence exists that biceps tenodesis has more favorable results and lower complication rates than SLAP repair and should be considered in less active patients or those older than 40 years. 5. Complications. A. SLAP repair, re-tear, stiffness, Persistent pain, rotator cuff tear from the transrotator cuff portal. B. Biceps tenodesis, biceps tendon rupture at the site, bicipital groove pain with proximal tenodesis, biceps pain particularly from overtensioning of the tendon, humeral fracture. C. Biceps tenotomy, cramping, fatigue or weakness of flexion, supination, cosmetic deformity. Top testing facts. 1. A normal synovial recess exists between the superior labrum and the articular cartilage extension over the superior glenoid rim. It should not be confused for a labral tear. 2. Slap tears can occur from direct trauma, internal impingement of the labrum on the posterior superior rotator cuff, or torsional force on the biceps anchor during throwing, causing a peel back of the labrum from the superior glenoid rim. 3. The sublabral foramen and cord-like middle glenoid humeral ligament are normal anatomic variants of the anterior superior labrum. Errant repair can restrict external rotation. 4. No single provocative test is sufficient to confirm the diagnosis of a superior labral tear or biceps lesion. A combination of sensitive and specific tests increases the accuracy of the physical examination. 5. Non-surgical treatment can resolve pain effectively and restore function in patients with slap tears or biceps lesions. 6. The surgical treatment of slap tears depends on the status of the biceps anchor. Degenerative or flap tears without the involvement of the anchor can be debrided. Labral tears with an unstable biceps anchor require reattachment to the superior glenoid rim or biceps tenodesis. Top testing facts. 7. Superior labral tears can be associated with paralabral ganglion cysts. Sphenoglenoid notch cysts cause isolated infraspinatus weakness. Cysts that involve the suprascapular notch cause supraspinatus and infraspinatus weakness. 8. Slap repair with subacromial procedures should be performed with caution because of the risk of stiffness. Associated pathology should be addressed when clinically indicated. In a concomitant slap and rotator cuff tear, no advantage exists to slap repair compared with biceps tenotomy. 9. Biceps tendon subluxation or dislocation should be treated with biceps tenotomy or tenodesis. 10. Biceps tenotomy has been associated with cosmetic deformity, cramping, and fatigue, but no substantial difference in overall outcomes has been demonstrated between tenotomy and tenodesis. This video was produced from the book source that was shown below. Boy Martin I. 2014. ALS Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Acknowledgement. We would like to acknowledge the editor Boyer Martin I and chapter author Mark S. Kowalski, MD, in preparing the text of this chapter in the previous edition. Citation. Boyer Martin I. 2014. ALS Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Thank you for watching my video. Please subscribe to my YouTube channel.